When our son was diagnosed with stage 4 cancer, we wanted to know everything science and experience has proven effective. What we found was a lot more than what we were presented with at the hospital. With so many well-trained, highly educated professionals operating outside the bounds of conventional medicine, it just doesn't make sense to limit ourselves when the stakes are this high. From interviews with world-renowned doctors and researchers to science-backed presentations given at medical conferences, when it comes to reversing or preventing cancer, this is where you come for the best of the best. I'm Ryan Sternagel of the Stern Method, and this is the Anti-Cancer Revolution. Very glad to have you with me for a special Best of the Anti-Cancer Revolution 2 episode with Dr. Dan Rubin. No, I don't mean it's a repeat episode of this podcast. I mean, this was a talk given at our last Anti-Cancer Revolution online event, conference, summit, whatever you want to call it. As I've mentioned before, we've gotten such amazing feedback with the in-person conference style format. This last one was, we're going to be featuring talks from other conferences on this show. But the feedback we also got was, I couldn't watch all the talks while the event was playing, and I'm bummed, I missed so-and-so. So I thought we'd sprinkle some of our own event talks into the podcast as well for those that missed them. This one isn't as much of a full-blown presentation as many of the others were, but it was a very deep dive into circulating tumor cell testing, which I feel is very important knowledge to get out there with the way this technology is advancing and how it can both guide treatment decisions and potentially minimize the need for conventional radiation-based scans. I read Dr. Rubin's bio at the start of the recording, so I'll let you hear that there. But aside from that, within the world of naturopathic oncology, Dr. Rubin has done more to make inroads for the profession into the conventional medical establishment than just about anyone else I can think of. He facilitates a whole lot of collaboration between the two worlds, which God knows we need more of, and we all thank him for it. Enjoy the talk, and I'll see you back here on the other side. Welcome back to the Anti-Cancer Revolution 2, everyone. I am Ryan Sternagel of the Stern Method, and in this session we have with us Dr. Dan Rubin, who is a naturopathic doctor based in Scottsdale, Arizona. His naturopathic oncology practice has been an integral part of the Phoenix metropolitan medical community for the last 20 years. After graduating from Southwest College of Naturopathic Medicine in '97, Dr. Rubin returned to SCNM to complete his residency in 2004. He became the founding president of the Oncology Association of Naturopathic Physicians, ONC-ANP. The ONC-ANP represented a revolution in the field of naturopathic oncology, providing for the first time definition, validation, and standardization of the field of naturopathic oncology. Since that time, Dr. Rubin has become an internationally recognized naturopathic oncologist. Dr. Rubin is the co-founder, along with his wife, Debbie Smolinski, ND and medical director of Naturopathic Specialists, LLC in Scottsdale, Arizona, and Aspen Integrative Medical Center in Flagstaff, Arizona, where he practices full-time as a naturopathic oncologist. At present, naturopathic specialist has served the clinical and logistical oncology needs of people from all 50 states, as well as 19 countries. He is also an avid trail runner, as I try my best to be when I'm not under the gun getting something like this done. Dr. Dan Rubin, how are you? And thanks so much for coming on.
I'm great. Thanks for having me. And I do look forward to having a trail run with you someday.
We'll make it happen.
Some elevation. It's great. I do want to say we do have a partner up in our Flagstaff clinic, Dr. Amber Belt. Just want to give a shout out to her too.
Yeah, very good.
Thanks.
Very good. Note there, everybody, definitely ONC-ANP, Oncology Naturopathic Physicians, has been mentioned a time or two throughout this event, and you're talking to the founding president. So thank you for doing that.
Thank you. Founded it with my good buddy, Dr. Jason Herman, naturopathic oncologist, whom I know you know too. And
also on the event.
Indeed. Lovely. Yes. He and I will hopefully see each other in a couple days. The real reason to bring ONC-ANP from not being around and to develop it and invent it was protection of the public. In this world of non-conventional oncology, we felt that as naturopathic oncology and the invention of the naturopathic oncologist was being important, it was very clear that if somebody is looking to consume non-conventional, natural, naturopathic, alternative, whatever word you want to ascribe to it, oncology services, it was important for the discerning consumer to be able to know who had skill and who didn't, because there are people out there who simply don't have as much expertise or experience or skill or true understanding, or not at the physician level. And it was important for us to demonstrate that within our profession, that there were those experts. And anyhow, thank you.
Yeah, yeah. Well, I've been to a few of the conferences now, and usually the only guy wandering around there without an ND after my name. But it's it's always I look forward to them so much, because it's that's where I learn a whole lot of stuff that you do, and that's kind of the inspiration for this particular event, the Anti-Cancer Revolution 2. Is it's those types of presentations that I always get so jazzed up about, and I wish that
I'm jazzed. This is exciting. I'm so happy. Thanks for having me on. I'm so happy you're doing this. I know so many people are.
Yeah, but it's always like I think the general public, especially the ones going through cancer that just are devouring information right and left, I think they have an appetite for this sort of information, and so I've managed to cobble together my best attempt at replicating an OnKNP for the general public, for the masses. So yeah,
Thank you.
Thanks for giving me the inspiration.
My pleasure.
But all that said, I'd always like to ask why cancer, to start us off before we get into the presentation.
I have a bachelor in existential philosophy. That was my studies. And I thought that I had wanted to graduate college and be an instruction manual writer. And lo and behold, I became one. I end up creating arguments for how people can help themselves, how I can help people, how they can understand their unique physiology, their disease, understand their health, how they can regain it, how they can prevent. And I end up every day, multiple times per day, writing instruction manuals, each time different for each person. No checklists, no spreadsheets. Starts with a tabula rasa, a blank slate, because each person truly is an N of one. And one of the most unique things we look at in people in our practice is their unique physiology or biochemistry. It's their lab testing. It's truly what guides a lot of our treatments. Cancer arises within oneself. That was intriguing to me. Cancer doesn't spare any system. It doesn't spare any tissue type. It doesn't spare any body fluid, any age, any gender. Cancer is still mysterious to us. And at the time, this is back, I'd say 1996, when I was in the last year of my naturopathic schooling, really started to move towards oncology and understanding that it would probably continue to provide a mystery, influence, and really just great inspiration for me to continue to want to help people and teach people how to help themselves, and brings me to what I think is my most important driving precept in naturopathic medicine, because naturopathic medicine is founded upon 6 guiding principles, one of which is Dokei-rei, or doctor as teacher. And that's what my colleagues, myself, practitioners, non-naturopaths who are in the health world are doing, is finding that educating each person each time you meet with them is rewarding and helps them continue to learn how to help themselves. That's why cancer.
Beautiful. Very very philosophical, Dr.
Hey, I was trained in it. Thanks.
I just learned 2 things there. One, there's this little strip mall type of deal that I get my hair cut at. More than a strip mall, but there's a store in there called Tabula Rasa, and they sell fine pens and various different books, and I always like to go in there and browse, but I never thought to ask what Tabula Rasa means. Now I know it means blank slate.
And two, I was always pronouncing it dossier, not Doque-Ray.
Indeed.
Now I know. Now I know. All right, let's get into it. So you are, yeah, I mean, you're kind of known for your knowledge and love of, well, maybe love's the wrong word, but you know a whole lot about circulating tumor cells, CTCs as they were, and I'm excited to share your knowledge with the world here. Do you want to start off by, they've been mentioned before, but not in the deep dive context we're going to go into just right now. Just start by, I suppose, talking about what are circulating tumor cells.
Circulating tumor cells are cells that are emancipated from a collection of cancer cells or a tumor or some type of metastatic deposit. It could be something that you can't see on scan. It can be something that you see on scan, but they are cells that are circulating in somebody's blood and that can be located and assayed through the blood by a laboratory, the correct laboratory. And that's simply what they are. Now, just because in the body fluids, they can also be in the lymphatic tissues, which is obviously a place where that has fluid and it has depots, which are called lymph nodes. We can't do tests, so to speak, for circulating lymphatic tumor cells. We can only do them in the blood. Obviously, a person can have a biopsy of a lymph node to determine if there's cancer in a particular lymph node. But that is a procedure, and it's not just a blood test. So that's what they are. They're just cancer cells circulating in the blood, and they're very important. And yes, I do love them in such a way. I love them in a way that they really are what I call a window into a world that we knew was there, but could simply just never see before. How do people get metastatic deposits? How does cancer spread? It has to go from one place to another. There's two general ways that are well described in the literature. There are some new theories coming out, but right now they're just theories and they're very, very early. But the established scientific knownities of how cancer cells spread are two ways. And I usually use this example when talking to patients. I go, if I'm sitting in my living room at home and I want to get into my kitchen, which is a couple rooms away, I could do one of two things. I could walk out the door, go down the hallway, and go into my kitchen. That's akin to me leaving a tumor site, going on a blood vessel, going into another tissue, and that would be called metastasis. Metastasis actually means evil spread. Just to put a definition to it.
Evil spread.
Evil spread. The other way that cancer can spread is by what's called direct invasion. And that's like, okay, if I'm sitting in my living room and I want to get into my kitchen, I got to break down some walls and I got to get into the kitchen. So I got a sledgehammer, I could kick my way through it, I could spread acid on the walls and melt the walls, and that would be called direct extension or local invasion. Many people on their pathology reports will see that they have an invasive tumor. Well, cancer isn't going to spread if it's not invasive. If it's encapsulated somewhere, then it's going to stay where it is. Once it invades the tissues that were once keeping it secure, then it has access to either the lymphatic highway or the blood highway.
Very good. So, two questions. One, we always hear this, kind of phrase or wisdom or whatever repeated that, we all are producing cancer cells every day. But it's when they get over, when your immune system can't handle them, or whenever they do a good enough job of evading the immune system, that's when you get what we would think of as actually having cancer. So one, how does that play into the circulating tumor cell discussion? And then part B, I suppose, would be, maybe these are two unrelated, I'm not sure, but just if you have if you take a circulating tumor cell test and find some circulating tumor cells in the blood, does that mean you're going to get have a metastatic tif somewhere?
Wonderful questions. And no, they're totally related. Absolutely. And thank you for asking them. Number one, what I should say is that if somebody does not or is not known to have cancer, you can't do a circulating tumor cell test to diagnose them with cancer to say, oh, you're going to show up with a tumor. That's something that is not done in the United States of America. But I want to make that very clear because there are some notions on the internet and I think some non-US based companies that are purporting that. And that has no basis in science that I know of, no basis in clinical medicine. We're not doing it. It's very scary. And it's just, in my opinion, not good science. Very scary. You mentioned that people have cancer cells sort of all the time in their body. And to some extent, that's true. We do develop cancer cells. What is a cancer cell? It's a normal cell that became non-normal because through some injury, it had a mutation in its DNA. And the overwhelming majority of cells in the bodies of humans that in which that occurs, the damage or the variant in the DNA or the genetic material is not severe enough to cause it to sustain itself, to evade the immune system, to be stabilized, then to make copies of itself. Those cells make copies of themselves, and therefore you have an establishment of a tumor. And typically, there is a self-destruct mechanism inside of those cells written into our genes that becomes activated when the cell senses that it has damage. When those genes or that part of the cell becomes damaged, that's when you start looking towards the development of a tumor, which takes some time because in order for a tumor to become clinically relevant, somebody has to have a symptom or it has to be found incidentally on a scan, and it has to be of sizable amount. So that's number one. I actually forgot you asked if a circulating tumor cell is in circulation, does it necessarily become a metastatic tumor? So no. The strict answer to the question is no. Just because they're there doesn't mean that it will become. So if somebody has a primary cancer and it's early in the diagnosis and we find circulating tumor cells, that doesn't necessarily mean that those cells will become another cancer or that they're coming from a secondary or metastatic site. And they don't live very long in the blood either. Circulating tumor cells don't. So persistence of those suggests that there is an occult site if you can't find it or that they're harbored somewhere. And so then that gets into really the science of the types of tumor cells, circulating tumor cells you're looking at and some of the various attributes of them.
Well, and then that leads to another question. And I think you kind of touched on this, but so is there a difference in quality or, the nature of a circulating tumor cell compared to, just a cancer cell that is encapsulated inside the tumor? Are they different types of cells or is it just any old cancer cell that happened to get out?
It could be any old cancer cell it can be any old cancer cell that gets out. It's not easy to be a cancer cell and survive in the blood. If you're from the prostate or if you're from the breast or if you're from the ovary, you're not a cell that's designed to live in the blood. I often liken it to me setting up a tent on a highway, simply not designed to go live on a highway or even on the shoulder. Something's going to happen. And if you're a big cell from a tissue in the blood, which is a very fast, very particular type of environment, then chances are you're not going to make it. But sometimes they do. Cancer cells tend to be hardy. That's why they persist. It's why sometimes they're hard to kill. It's why the immune system sometimes has trouble killing them. And quite frankly, it's why sometimes even the most toxic of chemicals that we can give to humans, or the most toxic of rays that can be sustained by human tissue without causing death, sometimes fail to kill those cancer cells. They can mutate. They're changeable. And that's the nature of a cancer cell, and that's what makes them difficult.
As far as just normal biology, I guess, does the body have any natural defenses against a circulating tumor cell?
I think there's a multitude of defenses, Ryan. I think one, and the one that's sort of, the big one is the immune system. But sometimes cancer cells don't show what they need to show for the immune system to attack. Sometimes the immune system sees a part of the cancer cell or the circulating tumor cell and sees that it is indeed part of the body. They don't see the bad part of it. They can only see the good part of it. And so they don't attack. I like to say that the cancer cells, whether they are in the tumor or whether they are circulating, can tend to seduce the immune system and seduce the other cells. You know, a tumor that lives in the tissues of a human being has to have sustenance. It has to have support. So there's nearby cells that, it's almost like the quintessential argument of good versus evil. The good cells want to nurture the body. And so if the cancer cell's sort of only showing the normal part of it to the rest of the body, then they're going to be sustained. But one of our anti-cancer strategies, and I think many physicians out there share, is reducing the hospitality of the body to the cancer cells, which I think many of patients out there and many of the people out there who are seeking care or taking care of themselves would call that optimizing health. And part of that is looking at what needs to be done. There are ways to do this based on precepts, and then there are ways to do this based on individual differences and looking at the personality of somebody's blood. And there are factors, circulating factors, that can demonstrate sustenance or the tendency towards sustenance or hospitality, if you will, to cancer in general or circulating tumor cells.
This is probably going to be an obvious question, but so we're talking about circulating tumor cells and testing. But I mean, so it sounds like it's a good idea to test for circulating tumor cells, and what are the benefits of testing for these guys?
I think it's a good idea. I do it as much as I can because it's another piece of information, and like I said, a window into the world that lets you see something that you couldn't otherwise see before. Now, the labs out there don't necessarily have approval for measuring circulating tumor cells in all types of cancer diagnoses. So more of the bigger ones, ovarian, pancreatic, breast, colon, lung, prostate. Those are the big ones where they have certification to do that. Why is it a good idea? Well, one, you can get an idea of, is there still cancer? So if somebody has, say, come through treatment, let's say they're doing an integrative model and they have breast cancer, which is usually the example we use. Somebody may have had chemotherapy to begin with, and they may follow that with some kind of surgery. They may follow it with some kind of radiation. They may, if they have estrogen positivity, they may go on an anti-estrogen pill or some kind of treatment. All along, they may be doing naturopathic or non-conventional or integrative treatment, and then they're doing some kind of health-related thing, following up with a naturopathic oncologist or allied health professional, and they're in the prevention of recurrence mode. Some people may have that exact same tumor, but they may do none of the above. They may only do non-conventional medicine. They may only see a naturopathic oncologist, or some people may see none and they take it into their own hands. Some may not do chemotherapy. Some may just go on an anti-estrogen. There's so many different variations or permutations of that. All the while, checking for circulating tumor cells gives you an indication of therapy response, whatever you're doing. So the best time to get a circulating tumor cell test is right away at diagnosis. Yeah. Then you get the best. I mean, that's really the best time to do any lab test, to tell you the truth. But you can gauge therapy response. One thing that it's wonderful for, but can be very scary for patients, and these are discussions that we have in our clinic with our patients, is making sure that they understand the gravity of the result, what it means, and it takes a skilled physician who understands circulating tumor cell biology and platform and what they mean to be able to talk to each patient based on each result. And so it's important that people understand that, like you asked me before, just because you find them doesn't mean it's going to set up a metastatic deposit. But if you're a year out, 6 months out, 2 years out from treatment, and you look for circulating tumor cells and you find some, that suggests something. Now, we know that some people with cancer get recurrences of cancer, period, the end. They do. We know that some people get them years after diagnosis or years after they're done with treatment and they're deemed cured. So if somebody gets a recurrence of a cancer that they had before, then they weren't cured in the first place, period. They just weren't. Watching circulating tumor cells in my practice helps me keep people on track, keep pushing them. It's not meant to be scare or a scare tactic. It is meant to keep them free of a tumor. And people can live long, healthy lives as long as they keep going, because preventing recurrence. And this is really one of the strongest places we use it. So, but it's always good to get it up front if somebody's diagnosed with cancer, when they have the most cancer in their body before any other treatment, whatever treatment they choose, that's, to me, the best time to get it, because then you get the best picture. Same as doing tumor markers. A lot of people run serological markers, like in the breast cancer example, CA53, CA2729, CEA, CA125, and they do it sometimes after treatment. And you don't know what they mean. You really know what they mean at the beginning. You see if that tumor is producing those or not. So there's variations on that. I'm sorry to bring other lab testing into it. But anyhow, I do hope that answers your question.
No, yeah, that's I never thought of it that way before, because that's, what you hear most from people who get a recurrence is, I went really hardcore on everything for a year, a couple of years, even a few years, whatever. And then, I started feeling good and started maybe not even falling back into eating McDonald's or whatever, but just not taking all their supplements and just taking it easy and that sort of thing. And then they get a recurrence. Yeah. So it's, if you got those CTCs, that CTC count staring you in the face, and that's a little harder to take it easy.
And then what happens if you get a 0 report? That feels good to somebody. It's like, what I am doing is working, so yeah, I'm not going to go back and eat that, the diet that I had before. I am going to continue exercising. I'm going to drink good pH water. I am going to get sleep. I am going to, fix my broken relationship with a loved one, those types of things. And it's motivating to see that 0. And I'm rooting those people on. But I do have discussions, and I'll say, for the people that are watching this, there are people who it's too nerve-wracking to look for. But if we bring up the notion of the test, and somebody doesn't want to do it because they're done with testing, they just need a break or something, it's still relevant, because there's that still keeps them going. It still keeps them active, even if they decline the test. So just the notion of the thought of being able to have it too is motivating in practice. And I think that's important for clinicians as well as patients to understand.
Yeah. No, that's huge. And, a lot, when you talk about natural or integrative stuff, the question, well, why aren't medical doctors using this? Well, then that's, everyone has the answer of, you can't patent curcumin and make money off it for the drug companies and that sort of thing. But just for this data of how treatments are or are not working, why isn't this a bigger thing in standard conventional oncology?
Oh, great question. It's a great question. So I have my opinion on this. Obviously, I'm not asking everybody, and I don't want to put my foot in my mouth, certainly, but I also I don't know, but this is my opinion. So there's different ways, or there's different technology platforms in which to look at circulating tumor cells. And I think that based on some of the FDA approvals and the tests that were sort of first to market, because they weren't as sufficient as the testing that I use in my practice, and I had used those early platforms, believe me, I used them off label, I used them, and this was, even working with our reps, like, I absolutely appreciate circulating tumor cells. We've been doing this work for over 10 years. Because of the lack of sufficiency or efficiency or efficacy in these, I think that a lot of docs were like, well, it doesn't work. We don't find circulating tumor cells in so many people. And I think that's because they got spoiled on the technology platform. It's my opinion. There's newer technology out. And so if you can't look for certain types of circulating tumor cells, then you're just not going to see them. It's like having your eyes closed or having one eye open or half open when you're trying to see something far away. Or if you have your left eye closed, you're not going to see something to your left. It's the same thing. So if your window's smudged, if your window's dirty, if it's blurry, then you just can't see it. So that's why the particular type of circulating tumor cell test I do looks for two different types, or two different populations, if you will, of circulating tumor cells. And it's incredibly important, because I can tell you the overwhelming majority ridiculously overwhelming majority of circulating tumor cells that are recovered by the lab with my patient population are ones that would otherwise not at all ever be seen by the labs we were using previously. And so that's the reason that I think it is. Now, there's another reason, I think, is that in conventional medicine, there are not as many pivot points as there are in the non-conventional naturopathic integrative world. We might be saying, oh, like you were talking about before, like, okay, oh, we found circulating tumor cells, or they didn't go all the way to zero. Maybe we need to change your diet. Maybe we need to add in some IV vitamin C. Maybe we looked at, maybe your estrogens are up. Maybe your transforming growth factor beta 1 is up. Or, yeah, you know what? There's some continued inflammation, or you haven't begun, something. We in this world, we talk like that. We have those pivot points, and in conventional, they don't have those. They can't have those, they don't. But that's exactly why I like to live in the world of integrative medicine, because I appreciate the heck out of conventional, and I appreciate the heck out of what I do as a naturopathic oncologist. And I find that it works very well being right there and understanding both worlds, and really being able to speak the language of oncology is important for a practitioner to see a patient if the patient wants to be in the integrative world. Not all patients want to see a conventional physician. We respect that. Anyhow, hopefully that answers the question too.
Yeah, it does. And yeah, that's a really good point about pivoting. And that's what was always really comforting to me when I started diving into the integrative natural side of things, is just, it can be overwhelming learning about all the different options and treatments and supplements and everything that are out there. But at the same time, it was nice to know that if things weren't going our way, then there's a whole new world of options and combinations of things that we haven't tried. And that's also where working with the professionals that have a few years of experience with this sort of thing, and such as yourself and other folks on this event, that are able to make those decisions a little easier than just you scouring the internet and trying to figure out what supplement to try next comes in as well. Can you get a little, I guess, more into the details of what it is we're talking about? Like, how are you testing for circulating tumor cells, and are there different types of tests, or is it all just kind of one standard format? Or just go into that a little bit.
Oh, absolutely. Yeah. So the lab that we use at our clinic is in San Diego, and it's called Biocept. Biocept, in my opinion, is leading the global charge for assaying circulating tumor cells. They have testing internationally, so my patients in other countries can actually have the circulating tumor cell test. Again, like I said, it's not for all tumor types. But why Biocept? Well, I think it's a great company, and their platform is the one that allows you to see two different populations of cells. And these cells are termed cytokeratin positive or cytokeratin negative. That's the key. That's the big thing, because other companies that I've tested from in the past would only look for the cytokeratin positive. May I expand and explain and give examples?
Please do.
So what is cytokeratin? What does it mean? So this is the example that I use clinically. I say, okay, pretend, and I also explain it like this to physicians that I speak with too and help educate about circulating tumor cells. Pretend you get on a bus and there's standing room only. You're going to stand, but you're going to have to grab that leather strap, up here to make sure that you're secured to the bus. So when it starts and stops and turns, you don't fly around the bus and hit somebody, right? When you grab onto that leather strap, you're cytokeratin positive. Cytokeratin is an anchor molecule for cells. Why do you need cytokeratin? Well, if you're a cell that lives in a breast, you got to stay in the breast. So you have to anchor yourself somehow, somewhere in there. And that they use cytokeratin. Now look, on breast biopsies, on lung biopsies, prostate, a lot of times the pathologist will stain for cytokeratin, various types of CK or cytokeratin, to determine if it's what's called an epithelial cell, or a cell that is from that type of, or suspected to be from that host tissue. That's beside the point. But cytokeratin anchors the molecule in. So if you're on the bus, you're cytokeratin positive. Well, let's just say that I make the decision to let go of the leather strap. I do. I'm now cytokeratin negative. I made that cognitive decision as a human being. If the bus stops abruptly, I go flying forward. If it starts up, I fly backwards, etc. If it turns, I go side to side. But I'm free to move about the bus. Well, a cell can make that same cognitive decision, if you will. They do it within their genes. And they change what's called their phenotype. They change what's expressed on the cell surface. Cells express themselves by putting things on their cell surface. There's many different markers on their cell surface. Cytokeratin is one of them. So if the gene decides to downregulate cytokeratin, it is now free to leave the tissue space and circulate and become a circulating tumor cell. Now, the cytokeratin negative is the key, because if you're a lab and you're only looking for cytokeratin positive cells, you're not going to find a cytokeratin negative cell. Those are the most common types of cells in my practice to find. Biocept looks for those. The other labs that I had tested before didn't. And that's where I think the problem happened, is because it's infrequent that you find a circulating tumor cell that's cytokeratin positive. But we should talk about how you find that. And I'll give an example. What's important about a cytokeratin negative cell really is that notion of why the cell downregulated the CK. When it does that, because cytokeratin is a marker of maturation, a mature, a differentiated cell, that cell that is now CK negative is thought to be akin to a cancer stem cell. I know, yes, the light bulbs are going to go off. That is a hot topic. How do you look? What about cancer stem cells? Are they resistant to chemotherapy? Are they resistant to radiation? Are they the surviving fraction that causes metastatic lesions soon or far after diagnosis or after treatment is complete? This is part of the key. This is what brings it all together. This is where my true passion and need for measuring circulating tumor cells. It's actually a clinical need, the way I look at it. How can I help my patients the best for the long term and remain free of cancer after initial treatment? This is one of the ways. So it's a masquerading. Down-regulating cytokeratin is if I want to walk from my office over there to the cancer center, our office is on a hospital campus here in Scottsdale, Arizona. The cancer center and research center is just behind me out that window. If I want to walk there and there's a lot of people outside, I don't want anybody to see me. I need to disguise myself, right? Maybe I shave my head. Maybe something like that. That's like taking down my cytokeratin so I can masquerade. You don't know who I am. I can get to another area. I can get to another tissue, another building, so to speak. And then once I'm there, if I'm a tumor cell, if I want to go to the bone and I make it there, now I reestablish my cytokeratin. I anchor myself in and I live. I made it. I got there. Now, when does that become clinically relevant? Well, it depends. Somebody can have a cancer cell in their bone, doesn't mean that it's going to live, but it may live. And that's where these long-term lifestyle issues come in, supplementation, watching other labs, etc. Like, that's why in my clinic, I do a lot of testing to look for bone integrity, not just like an every 2-year bone density test like a DEXA. I mean urine test, blood test to look for what's the health of the bones? How are they doing? Are you doing your weight-bearing exercise? Are you doing planks? Are you doing these types of things? But I'm also looking to see if there's net breakdown of bone. Why it's important, especially if a woman with estrogen receptor positive breast cancer is on an anti-estrogen known to reduce bone density. Why would we not want to check that? Why would we not give bone strengthening nutrients and diets to make sure that we reduce the potential of those tissues to be weak and accept a metastatic input? That's the philosophy of naturopathic oncology that is lacking in other disciplines, and that's why integrated medicine is so important. We fill that gap, and that's what you can do with the circulating tumor cell test. Can I go to cytokeratin positive?
Yeah.
Okay, so so we talked about cytokeratin negative, what it means, masquerading, getting to a tissue, downregulation of maturation markers. But what if you're a cytokeratin positive cell and you're in circulation? How did you even get there? Well, pretend I'm holding on to the strap. I'm cytokeratin positive. I'm anchored in. I'm locked in. Okay, so the door opens. I'm holding on. Somebody barrels in, runs into the bus, tackles me. I rip the strap off. I didn't choose to be in the middle of the bus. I'm cytokeratin positive. So how did I get forced into the middle of the bus? How does the tumor cell get forced into the blood? A couple ways. Well, it could be from trauma. Look, tumors are sitting in tissues. And as a tumor goes and gets some elbow room, it pushes against the tissues, which push back, right? Because in some spaces, it's pretty confined. So you have this sort of what's called mechanotransduction or mechanical forces pushing in on the tumor, and it can just kind of pop off, especially in an invasive tumor. Because if you're invasive, you have access to the blood. And the only way to get into the blood, you got to invade the tumor. You got to invade the blood vessel. Or if you're a growing lesion and you're growing, you have an invasive front, you have an invasive sort of margin, if you will. And if you're an angiogenic tumor, meaning you're growing blood vessels, and I mean, every tumor needs blood vessels to grow. Every tissue needs blood vessels to grow. We know that. You need blood vessels to heal a wound, to recover from surgery, to grow from a kid to an adult. And if you're a growing tumor, you need blood vessels. Well, at that invasive angiogenic interface, if you're a proliferating tumor, cells are just going to kind of knock off into the periphery. So if somebody has a circulating tumor cell that's cytokeratin positive, or a group of them, that may signify something different than a cytokeratin negative cell. That gets complex. That's probably reserved for, one-on-one patient consults, because then that gets more into individual clinical issues.
And aside from cytokeratin, is there anything else relevant that you can see about the circulating tumor cells with these tests?
You're a genius with your questions. Thank you very much. Yes, absolutely. So you can actually see some of the markers that somebody would see on an initial pathology specimen, like in somebody with breast cancer, like an estrogen receptor, or progesterone receptor, HER2. You can look for PD-L1. These are things that actually sit on the surface of cells. And so one of the really important ones is androgen receptor. So if you're a person or a man with prostate cancer, which is driven by androgens almost all the time, right? And the circulating tumor cell is androgen receptor negative, and it's cytokeratin positive, that may be an issue, especially if somebody's on androgen deprivation therapy. If somebody has breast cancer and it was, let's say, greater than 95% estrogen receptor positive on pathology, and they have circulating tumor cells that are cytokeratin negative but estrogen receptor negative, that becomes a clinical issue and something up for discussion. So it tells you individual personalities. One very important example, somebody who has a woman with triple negative breast cancer. So it's estrogen receptor negative, progesterone receptor negative, and HER2/neu negative, triple negative. Don't go on anti-estrogen therapies. But what about androgens? So I really appreciate the lab, Biocept, being able to measure androgen receptors, because instead of estrogen helping a tumor to grow, sometimes androgens are testosterones, androstenediones, DHEAs, those types of things that haven't yet converted into estrogens. And so I find that, very important. So yes, there are markers, and it's very important. And I should say here really quickly, circulating tumor cells and the markers that are found on the cell is different than circulating tumor DNA. Both of these can be considered liquid biopsies. One is actually looking at a cell, a living tissue. Another one is looking at a product from that cell, or mutated DNA, which is the majority of what's in the news. But just to save for confusion, those are two different tests.
And so either a circulating tumor cell test or a circulating tumor DNA, those would both be considered liquid biopsies, because I hear that term getting thrown around a lot, just different types of liquid biopsies.
Exactly.
Okay. And is there a time and a place for both types, in your opinion, or?
Oh, yes, absolutely. And sometimes through Biocept, I'll run both circulating tumor DNA, I'll run a CTC, and then other labs too are very good at running circulating tumor DNA, and some have big panels, some have small panels. Sometimes you can run an individual marker if you're really trying to hone down and look for something. Or let's say you found a positive on a circulating tumor DNA and you just want to hone in and only continue to measure that one. Some of those labs like Biocept will just measure one, and absolutely, and that is also another way to follow treatment response or to look for changes.
Very good. I think we covered a lot of, what the tests are, but I think that, the $1 million question for a lot of folks that are watching this is, okay, you found some circulating tumor cells in the test. What now? What do you do?
You talk to your doctor. Absolutely.
Well, what do you do when you find them then?
Oh, got it. That is the big question. So I will use that N of 1 example, and it sort of depends on who my patient is in front of me, what we're able to do. If I'm seeing somebody at a distance, obviously they can't come into the clinic and receive treatment in the clinic. So, what is in their local area? What do they need? What have they been through? What is the cancer? How did it begin with anyhow? What did it begin with? How serious was it? How aggressive was it? What treatments did they have in the first place? How are they coming to me? And so it's really, really important to know the overall situation, because it's not just the same for everyone. It truly isn't. It's the beauty of medicine, is to be able to really look at somebody as an individual. What now? Run other lab tests. Look at supporting factors in the blood and then fix those. Inflammatory markers, cell markers, immune markers, tissue markers, supportive markers. I mean, there's a host of markers you can run. Hormones. But then also look at the tissues that may be at risk. Many types of cancer can metastasize to the liver or the lung or the bone. Make sure those are strong. Looking at your toxic load, looking at your diet, looking at your house cleaning products or your body products. What are you using in the shower? What's the quality of your water? Are you filtering your water? How's your air? So just the general things that some don't necessarily think about, but that happen every day and that allows things into our body. Your bones, like we talked about before. How strong are your bones? Do you have a predisposition to osteoporosis? Are you osteopenic? Are you doing enough weight-bearing exercise? Can you even do weight-bearing exercise? I mean, there's people out there who simply can't due to medical conditions, or some people don't like to do it. There's a lot of people who don't like to exercise. So how do we help those people? Look at your nutrient levels, look at your D levels. Look, important point, if you're measuring vitamin D levels, you got to measure both kinds, not just the 25 hydroxy, but the 125 dihydroxy. Look at it, look at the balance. And then think about, what do we want to do from an anti-cancer perspective? Does somebody have an existing tumor that's measurable on scan and they have circulating tumor cells? So let's say somebody does have a metastatic lesion in their liver. Let's say it's 3.2 centimeters. And they're on treatment. And I don't know what treatment that is. It can be integrative, it can be conventional, it can be non-conventional only. It just depends. Are they on treatment? And let's say we find 14 circulating tumor cells in the blood and 36 milliliters of blood. We say, okay, that's a reasonable amount of CK negative circulating tumor cells. Let's do something about it. So we change the treatment based on the labs. We fix everything that we need to have fixed. We rerun it 2 months later. There's 4. We do a few more things, whatever it may be. And then 2 months later, it's 0. Get a scan. Here you are 4 months later. Scan, it's stable. Lesion's 3.2 centimeters. Still there. PET scan's still positive. SUV may be the same. Maybe it's 5.6 SUV, but we've shut down the outgrowth. We shut down the outpouring. That is one of the first steps. So when I look at a scan, for instance, what I like to see is nothing new, nothing grew, and something shrank. And once you start shrinking, you can take it all the way to it's not there anymore. And that's the obvious goal. But that's the limitation of scan, is you can't see what's circulating. And that's why you have to pair these together in my world. It's important to do it. Now, remember, not all diagnoses are allowed to have circulating tumor cells, and that's just because we're just not there yet.
Yeah, good deal. And then lastly, I don't know exactly how to ask this, but from a, integrative natural therapy treatment supplement standpoint, obviously this whole event, people have been throwing out various anti-cancer agents. but within the context of circulating tumor cells, in particular, anything that kind of stands out to you there, your go-tos for circulating tumor cells, if that's even a valid question versus.
That's a hard one. As a licensed physician and the member of our Naturopathic Physicians Board of Medical Examiners in the state of Arizona, I really don't feel comfortable giving out something that somebody can just go access because it may be contraindicated for them. And so, with all respect to you, I'm going to refrain from saying something. Now, on the other hand, things that they can't get by themselves, or I hope that they can't get by themselves, something like intravenous vitamin C, which I'm very comfortable talking about this, or physician-guided treatments. These are important. Intravenous quercetin, mistletoe therapy, those types of things are important. Why would IV vitamin C? I don't think it's a cliche. I mean, it's still one of the most relevant things. Some people might think it's a cliche. Oh, just throw IV vitamin C at it. And you know what? A lot of docs may throw IV vitamin C at it. I consider myself an absolute expert in IV vitamin C. I still use it, absolutely. It still remains one of the most powerful, one of the most reasonable things, but it's how you use it and why you use it. Those are what's important. The rate at which it's given, the dosage, the peak plasma levels, the reasons why, the frequency, the scheduling, that's how you have to give IV vitamin C. Generic dosages of 50 grams once a week to somebody, I mean, that may help, but it may not be perfected. Why is IV vitamin C important? It's an anti-angiogenic. So if somebody has a lesion in their body that's emancipating circulating tumor cells and you reduce angiogenesis, you reduce the growth potential, you can start shutting off the faucet, so to speak. It can help increase the integrity of tissues. Vitamin C is needed for collagen production. Why is that important? Well, if you're reducing the risk of metastatic spread because you are strengthening the tissues at risk, that would be important. Also, we talked about some of the forces. If you have a tumor and you have surrounding connective tissue, that needs to be strong so we can keep the tumor. We don't want the tumor to continue to invade through, because with that invasive front, you can get emancipation of circulating tumor cells. It's an anti-inflammatory. It's an immune stimulation agent. It has direct anti-cancer activity. So those are the reasons that I would pick that, and that I don't think it's cliche and I don't think it's necessarily generic.
An oldie but a goodie. Yeah,
totally.
Yeah,
Sorry, you got me going.
No, yeah, it's I've come back to this a lot, and I think I was just joking with Dr. Anderson, Paul Anderson, about this. Is for a long time I was trying to reinvent the wheel in terms of scouring the internet and going through every PubMed study I could find, and all sorts of different cell studies and neuroblastoma in particular, and trying to see all I could see and all this stuff. But at the end of the day, there's there's a reason that some of these things have just been around for a long time, and it's like, oh yeah, I've heard about that, what's the next thing? But no, there's a reason you've heard about these particular things, and that pretty much all the clinicians use them, and that should probably tell you something. Yeah,
indeed.
And yeah, anything else you feel like we didn't cover that you want to throw out before we wrap it up?
I want to thank you for doing what you're doing and for disseminating great information, bringing on great guests. I feel privileged to be a part of it. I think you're doing excellent work, and it's been a privilege to know you and watch your work.
Yeah. Thank you for the kind words. Right back at you with,
thank you.
I don't know if you mentioned it or not, but you see a lot of kids in your work. Something that, unfortunately, I get it, but unfortunately not all integrative physicians are willing to do, especially in cancer. And it's nice having a trusted source to be able to send folks looking for good information for their kids for. So thank you. Right back at you for that. Yeah.
Thank you. You're welcome.
Dr. Dan Rubin, it's been a pleasure. You want we mentioned it, earlier in the bio, but let everyone know again where to find all things Dr. Dan Rubin, where to follow up with you, social media, all that stuff. Do you see patients remotely or just in person?
Yep, no, we do remote consultations, absolutely. Our main website is listenandcare.com, all written out, listenandcare.com. That's our main URL. That's our Scottsdale clinic. Aspen Med Center is our Flagstaff clinic. The phone number, I'm going to give the phone number.
Why not?
480-990-1111. And on our website are certainly our links to our social media. Thank you.
Very good. Very good. Dr. Dan Rubin.
Thank you.
So much for coming on.
Bye.
That was Dr. Dan Rubin, everyone. I am Ryan Sternagel of the Stern Method, and we'll see you on the next one.
There you go. If you'd heard of CTC testing or liquid biopsies before and weren't quite sure what was going on with that, well, now you're an expert. Episode notes, links to all resources mentioned and so forth can be found at thesternmethod.com/Dan-Rubin-CTC. Again, I think particularly as this is being covered by insurance more and more, this is definitely something to be asking around about to get all the information you can as to what's working and what isn't and make the best possible decisions you can. Hopefully this is the only announcement I'll make about this without actually having a show to point you to, but I wanted to give you a heads up on the new show that's been in the works. We're just about ready to release our first episode for The Great Work of Healing. I've been casually describing it as a blending of my love of natural health and healing with my interest in the weird stuff, you might say, overlaid with how are we going to keep the freedom to do what we know to be right for our health. Reason for it being, I want to keep this show strictly about cancer and what's proven to help, to really differentiate it from a generic health show and be the most helpful thing possible for people concerned with cancer for one reason or another. But then again, there's a lot of other relevant stuff I want to get out there to the world, so we decided an entirely separate show was the best way to do it. You can, of course, periodically search iTunes, Stitcher, etc. for The Great Work of Healing, but probably the easiest way to ensure you get the new episodes when they come out is get on our email list if you're not already, which you can do at thesternmethod.com. That's all for me. I am Ryan Sternagel of The Stern Method, and if you are going through cancer, just keep going.